of ergonomics and human factors, and our launch today of our pharmacy special interest group white paper on using human factors to support clinical decision making. Human factors has long had an important part to play in the processes that underpin what pharmacists routinely do, and this promises to be a fascinating session. I'm Steve Barraclough, your room host for this session today. You'll shortly be hearing from our chair, Helen Vosper of Robert Gordon University, and alongside Helen are David Gibson, Dominic Furness, Hannah Bieber and Emma Pearson, who you'll be hearing from either in person or by video, and who will be on hand to answer questions via chat. Okay, everyone, as many of you regulars will know, is welcome to use the open chat function to make comments at any time, to say hello, or to pose questions as we move through the next hour and a half or so. Please do be aware that everything you show and put into chat will be seen by everyone in the room, and also be seen by a much wider audience potentially who watch this recording. So please keep your input as respectful, thoughtful, professional, inclusive and as free of jargon as I know you will, and as you yourself would hope to receive in a respected public forum, and that you would wish to find recorded as a session branded by our institute. So thank you. Keeping your questions succinct will also greatly help our chair and panel to answer you on point and within the time available. Please be aware that we may not be able to answer every question that comes forward. We've a largish and it's great to see audience tonight, so please bear with us. Now, if you are unfortunate enough to experience either poor sound or imperfect video or imagery as we go during this session, then please first do check the operation of your device, of your internet connection, your power supply and your sound source. And please also be aware that if you're using a browser other than Chrome or Firefox, our recommended browsers, then your enjoyment may be impaired. If you're electing to use a mobile internet connection for this session, then please do check the signal strength before you seek help in the chat, which you can do. So if all that's failed, go into chat and I will aim to sort you out as quickly as I can. You may find that using the red button top center screen to reconnect, or by leaving the room by closing your browser, may well repair the problem. So try that first. Okay, if all that's failed, as I say, let me know via chat and I'll be pleased to help. Okay, it's great to see a large audience here today for what is, I'm sure, an interesting session. So with a final reminder to all our speakers, please, to keep your cameras and mics on mute unless invited by our chair. Let me now introduce to you our chair, Helen Vosper of Robert Gordon University.
Wonderful. Thank you, Steve. It's fantastic to welcome you all to this event. This is a collaborative event between the Chartered Institute and Health Education England. First of all, I'd just like to introduce you to the presenters that you'll see today. There's myself, Helen. I'm an academic, but I'm also co-chair of the pharmaceutical sector group here at the Chartered Institute of Ergonomics and Human Factors. And I've been the co-lead on this project, providing some of the human factors input. And I've been working alongside David Gibson, who's the lead clinical pharmacist at Darlington Memorial Hospital, but is also on secondment to Health Education England, where he's the Foundation Pharmacist Associate Dean. And I did notice on his Twitter page today, he's also a fell runner, so kudos to you, David, for that. Dominic Furness is a Senior Human Factors Consultant at Human Reliability Associates, and he's also a very active member of the Pharmaceutical Sector Group, and he's been my Human Factors wingman on this project. Now, in order to ensure the credibility of these resources, we've been working closely with a number of clinicians, and I'm absolutely delighted that we've got two of those with us tonight. Firstly, we've got Emma Pearson. She's a clinical pharmacist, but she's also on secondment to Health Education England, where as a clinical leadership fellow, She's working with David in delivering the Foundation Pharmacist programme. When you become familiar with the resources, you'll see that we've used personas to help contextualise the different levels of decision-making maturity. And we've actually got one of those personas with us in the flesh today. Hannah Bieber's our diabetes pharmacy expert, and she's the Senior Clinical Pharmacist in Diabetes for County Durham and Darlington Foundation Trust. But she's also a Diabetes UK champion, and she's co-chair of the UK Clinical Pharmacy Association Diabetes Committee. So hopefully you'll feel you're in good hands. Now, just to give you a little bit of the background, I can see we've got quite a varied audience here, and some of you will know more about this than others. But this is about supporting people as they move from the educational environment and into clinical practice. I think that's a challenge for any healthcare professional, but particularly so for the pharmacist. Now, I know a lot of you will know about this, but for some of you that aren't familiar with the pharmacy environment, there's some kind of legacy issues from education and training. Our pharmacists do a 4-year undergraduate degree in which they have relatively little exposure to the clinical environment. And most of the clinical experience then comes right at the very end, after they've left university and they go and take up a pre-registration post. At the end of that, they take the pre-registration exam and they enter onto the register if they're successful in that exam. So they find this transition particularly challenging, but as David will talk about more, COVID, of course, has exacerbated all of that. And I think this would be a perfect place, Steve, for us to see the video from Helen. Thank you.
Hello, my name is Helen Porter. I'm the lead dean for the Interim Foundation Pharmacist Programme, or IFPP for short. My message is for all provisionally registered pharmacists in England. We set up the IFPP in response to the pandemic, our main goal, to help you achieve full registration and to launch your career as a pharmacist. We want you to develop the skills that you'll need to help you achieve high quality outcomes for patients and to improve patient safety. We also want to learn from the IFPP. We want to capture the lessons learned to help inform the future education and training of pharmacists. So think of the IFPP as a gateway to high quality learning, which includes events such as this one, but also education supervision if you're in employment. If you haven't registered for the IFPP yet, don't worry, you can still do that. And that is more relevant now than ever. We heard from the GPHC that the exam will take place in March. It's good to know when it will happen, as we can start preparing for it and building your foundation learning around it and beyond. We are committed to helping you launch your career and to provide safe and effective care for patients. We hope that this event, as well as the education supervision, will help you to make sense of the complex clinical environments that you're currently working in. This event couldn't have taken place without colleagues at the Chartered Institute for Ergonomics and Human Factors. So on behalf of Health Education England, I would like to extend my thanks to our colleagues at the Institute for facilitating today. So please enjoy the session.
Wonderful. Thank you, Steve. So for those of you that don't know, I'd also like to tell you a little bit about the Chartered Institute. Many of you will have heard of human factors. In healthcare, sometimes that can be a little bit misunderstood. But essentially, we're the professional body in the UK for human factors specialists. You also see ergonomics in the title there. Well, human factors and ergonomics are the same thing. And essentially, it's all about taking an integrated design approach to improving life, well-being and performance. We draw on a number of different disciplines, and those will include things like engineering and psychology, design, physiology, etc. But all of those coming together to think about how we interact with our work systems and how we optimize performance, but keeping human well-being right at the front of it. The Institute's one of the largest human factors professional bodies in the world, and this has been such an exciting time to be part of the Institute. We're growing in numbers every day, and we're having lots of opportunities like this collaboration with HEE to really bring about some impact, which is very exciting for us and hopefully for you. And I think HEE and the Chartered Institute, with our interest in human performance and well-being, it's a natural synergy between our organisations. So briefly, just to go through tonight's programme, after this introduction, I'll introduce David, who will talk about some of the issues around complexity and decision making and the impact that has on pharmacists. Then we'll move on to thinking about some of the theory behind systems thinking and complexity, which I think will be very useful for you in understanding the resources. Finally, I'm sure you're interested in the theory, but also in having practical tools that will help you in the workplace. And I'll talk you through a little bit about how we develop the resource and the models that it draws on to support performance. One of the things you'll hopefully see from the resource is it's all about facilitating discussions that make understanding decision making slightly easier. It's still challenging, and helping you develop that decision making skill. And so we're going to show you a video that actually looks at a sort of discussion that might happen around these resources. Finally, David will come back and talk a little bit about how he sees these resources being used, and then we'll finish off with a Q&A session. So I shall now hand over to David, and if you could unmute your microphone and show the video, your video, that will be excellent. Thank you.
Great, thank you, Helen. So I think firstly we're starting with a quick poll to just find out who we've got in the audience and what your interest in the sessions are. So I think Steve's just going to set up that poll for us. Is that coming? So if you see on the right hand side there, we've got the poll that's been filled in now. That's excellent. So it's looking like we've got quite a few foundation pharmacists who are on the IFPP there, plenty of educational supervisors, and then some other pharmacists working in practice, lots of human factors experts as well, and then people from other disciplines who are also interested. So thank you very much for responding to that, and we'll then move on to the main bulk of what we're going to talk about. So as Helen said, what I wanted to just discuss first was, why does pharmacy kind of care about complex decision making and the complex environments we're working in, and also just a little bit of a kind of consideration about the evidence of why pharmacists need to develop kind of complex decision making as they kind of develop their careers. And finally, on my section, just a little bit of a consideration of what the impact of COVID has had on complex decision making within pharmacy. It's worth starting with kind of what the NHS policy is with regards how pharmacists are going to be developed in the future. And the people plan and long-term plan within England are talking about pharmacists increasing their kind of need to deliver patient-centred care. And that includes pharmacists acting as prescribers, enhancing their clinical skills and enhancing their consultation skills. And you can see from that long list there that pharmacists are already starting to practice in a large range of clinical environments. And as we develop those skills and those roles, then our ability to be able to deal with complex clinical environments is needed to increase. So what do I mean by complexity? So when we think within healthcare and the NHS, so when we're thinking about kind of complexity, there's a system-wide approach. You've got the patient as the kind of key kind of person involved with this, but you've also got the kind of healthcare team that you're working within, and wider than that, the organisation you're working in, and then even the healthcare system. And you've got lots of influences within that, things like policy, things like kind of finances, etc., of the drugs that we're managing. And in the centre of all that, we need to optimise and tailor the decisions we're making to make sure that it is right for the patient within the system that we're working within. And so we need to interpret the information we've provided to make sure we've got the tailored and individualised approach for patients. Unfortunately, COVID has come along and added another extra layer of complexity. We've all, as pharmacists, had to kind of adapt to working with PPE. The healthcare pathways are massively disrupted, so the usual routes of referral, etc., are changed. We've had closures of services, and pharmacy has actually kind of stood up and become one of the kind of key ports of call for patients. We've remained open throughout the pandemic, and so pharmacists have been seen as kind of one of the areas that patients come to for help and advice with their health. But we as professionals need to be able to manage and support them with the complexities of the environment that we're working in. So when we think about kind of complexity in a pharmacy context, I think it's really helpful to think about that patient-centered approach that the kind of traditional medicines optimization model just shown here is a really useful way of understanding that you've got the patient at the center of everything we're doing, but we need to balance the decisions we're making, understanding the patient's experiences, tailoring what we're doing to them, whilst also thinking about the kind of best evidence base for what we're doing, thinking about organizational pathways and processes that we're working within, and thinking also about kind of value for money considerations and safety considerations. So lots and lots of impacts and influences on the decisions we're making. So in other words, if we kind of want to achieve improved patient outcomes, pharmacists need to individualize the care that they're providing for patients. And this is where the kind of complexity and the ability to make good quality clinical decisions comes into the picture. So how do we describe this within a kind of educational and a development kind of context? So as pharmacists develop their proficiency, decision-making skills need to be kind of refined and developed. And so I've highlighted on this slide the two kind of capabilities that have been pulled from the kind of foundation, the IFPP framework, and the advanced practice framework for pharmacists. And you can see there's a very clear evolution of the kind of decision-making that needs to be kind of developed as you develop your proficiency towards advanced practice. And like I said earlier on, the NHS and patients are requiring pharmacists to practice at that advanced practice level to be able to kind of fulfill all those extended roles that are being developed within the NHS. So the challenge is that actually complexity can potentially become a barrier to people developing their career on that kind of that spiral of towards advanced practice and ultimately consultant level. And to break down that barrier, kind of clinical decision making is a key enabler. So this diagram describes that kind of journey of a pharmacist to meet those requirements that patients need within the NHS. So moving on to kind of what is the evidence behind this? And some really good work being done by Esnath Magoli, who's based in Manchester, talking to foundation pharmacists working in community. And she found that often pharmacists feel kind of quite professionally isolated when they immediately qualify kind of post their pre-reg when they come into foundation. That lack of peer support increases that weight of accountability, and that hinders development of confidence and reduces the autonomy as a practitioner. So that reduced autonomy and the lack of confidence reduces the willingness to make complex decisions. So what we want to do within the IFP and IFPP is to support you as a provisional registrant pharmacist to actually develop that confidence to be able to make good quality decisions and be able to kind of put the patient at the center of the decisions that you're making to be able to kind of develop your practice. Other work that's been done is some work that has been done within the Northeast and North Cumbria kind of clinical pharmacy network, looking at hospital practice. And they found that the kind of main barriers to developing kind of confidence within complex scenarios was that ability to kind of make decisions that relate to deal with the complex scenarios, were more likely to be active prescribers and more likely to be practicing at a more advanced level. So you can see that developing those kind of complex decision-making skills are key to be able to put the patient first and at the center of all our consultations, to be able to kind of deliver on the aspirations of the NHS and the profession as pharmacy, and to kind of, for us as individual pharmacists, to really be able to develop our practice towards kind of advanced levels for caring for our patients. So that's my summary of where we are. I'm going to hand back to Helen as the chair.
Wonderful. Thank you, David. That was great in setting the scene. And it's great to see the chat going so well. And thanks to everyone who's answering the questions in the chat. That's really, really helpful. Now David set the scene, I'm going to hand over to Dominic, who's going to introduce you to some of the theory that we considered when we were thinking about developing these resources. So Dominic, if I could ask you to switch your camera on. Thank you.
Thanks, Helen. Okay, great. So yeah, I'm Dominic Furness. I work for Human Reliability Associates. I've been working in human factors for over 10 years. Before joining the company, I worked at UCL as a postdoctoral researcher, and I worked on a study of NIHR-funded study looking at intravenous infusion practices across different hospitals in England. And I'd like to draw upon that experience as I talk about complexity and systems thinking. So we're going to talk a bit about what we mean by complexity and also systems thinking as a mechanism for understanding and grappling sort of with this complexity. And some of this resonates with what David's already spoken about. So some people use complicated and complexity as synonymous terms. They use them interchangeably. Sometimes where they do draw a distinction, then they just mean something that's really, really complicated. So more than just a little bit complicated, we're going into complexity. But other people, as we'll move on to in the next slide, that they think that complexity and complicated are actually quite distinct, different things, and should be treated perhaps in different ways. So in terms of complexity, we might think about different types of interactions. So when we're thinking about the performance of intravenous infusion practice in hospitals, so hanging bags up and setting up syringes to pump drugs into patients, we're not just thinking about the equipment and the bags and getting the rates and dose right, but we might be thinking about other types of things that you might consider on the periphery of the system. So thinking about the shape and design of the ward. So if a patient is on a gravity infusion and you need to keep an eye on them, then it'd probably be good to keep them in the busy area next to the nurses station rather than down the corridor and around the corner. We're thinking about the equipment, the usability. We're thinking about the procedures. Is it a high-risk drug, low-risk drug? The sort of risk assessments involved in that. And so you can see here that actually from what seems at first sight is a fairly simple system where you would just hang up a drug and set the infusion, you can see it as a complex socio-technical system. So it is a system that involves equipment, different people, policies, practices, and affected by the physical layout as well. So those are different types of things. Complexity is associated with dynamic systems, so lots of moving parts, is not really static and it keeps moving. It's an open system, so we might think that there might be a lack of people on the shift that day. That could impact double checking and other things. Also, there might be a lack of stock, so pharmacy might order a different brand of medication. That also impacts the performance of the system. Complex systems, the history is very important. So we're not starting from square one. There's a history involved. I went on a ward that was really good at doing their patient ID checks, almost too good. You know, they would do them religiously, even if they'd only just seen the patient. And I found out that actually the ward had a really bad time with some CQC criticisms. And so they had really put a focus on that. Other people as well talk about intractable systems. So there's so many interactions that all we get to see is what emerges out of all of those interactions, and non-linear. So some small effects can have big changes, and some big effects can actually have very small changes. So there's some characteristics of complexity. I really like this Cynefin framework where Snowden draws a distinction between different types of system, and this can help sort of analyze a system and move from different regions. So in the bottom right hand corner, we can start off a fairly obvious simple system. So these are systems where best practice can be employed, and we might think of something like a simple factory manufacturing line. If we move on to the top right, complicated systems, they're not so simple, but you can analyze all the different facets and things that are going on, and you can work out good practices and good options for finding the route forward. So this might be something like rocket science. So it's fairly closed system engineering. We can do the maths and work out what should happen. In the complex domain, this then leads to more complexity, and it becomes really hard to predict anymore exactly what's going on. And we might just be left in a state where we need to probe, do experiments, and get feedback from practice to see what's going on. And Snowden relates this to sort of something like organizing a children's party, which is a really complex scenario. In the research that we did in intravenous infusion practice, we've got some examples here. So labeling infusion sets might be something more simple, where we can define best practice. So if we're only concerned about infusion sets going out of date, so they might be used sort of more than 24 hours, we might label them. And also if there's more than one drug, then we might label them. So we can consider best practice there. Complicated, we might think about pre-made drugs in ICU. I was on a ward where they had pre-made propofol, but not pre-made noradrenaline. And when I asked the matron about this, he said, well, there's lots of things to consider there, like cost-benefit analysis. Also, where does he store these pre-made drugs? Because there might be issues with confusion there. But that, again, is a scenario where we can work out exactly what's going on and come to some good ways forward. More complex is we heard from a site that had difficulty getting good quality reports for learning from incidents. Now, they treated that as a simple sort of problem, in that they thought it was to do with the template of their report. But actually getting advice from a different site, they thought it was a complex problem, because it was to do with creating a culture of reporting and learning, so people felt safe to share things and fill out the report template sort of in a more in-depth way. There was an example there on double checking, but you can look up the Eclipse project if you'd like to read more about that. So when we're thinking about how much complexity that we can cope with, we can think about sort of our advancing expertise. When we're starting out with something, we can be sort of overwhelmed with the input from the environment. And so we can really just focus in on those things that are most closest to us. And thinking about doing our driving tests and lessons, you might, at the very beginning, only be thinking sort of about the steering wheel and the pedals and getting the car moving. As we progress up and we get more competent, then we can think about not just the driving instrumentation within the car, but also the way the car's moving on the road and turning corners and everything. And then when we're at expert level, we've almost take those first lessons for granted, and we can negotiate with novel road layouts and things, even ones that are challenging to us. But we know the patterns there, and we know what to look out for. This sort of thing could be similar to developing skills and competence in pharmacy as a prescriber. So at the beginning, maybe focusing more on the drugs and thinking about those simple rules for if patients got disease X, then we use drug Y. In sort of an intermediate stage, we might be dealing with more complex scenarios where there might be different options for patients. So we can work through that with them and see what might be most appropriate with the patient. And then in the expert scenario, where we're talking about more complex cases, there might not be any right way forward. An example perhaps might be someone like my granddad with lots of different conditions, lots of medication, and all the medications sort of and conditions play off each other. So it might be a case of, just trialing, probing, seeing what works and what doesn't, and developing from there. So just to finish off on the final slide, when we're thinking about all of this complexity and the different things that might be involved in our decision making, systems thinking doesn't try and reduce those things. Sorry, that's my alarm to stop talking. Systems thinking doesn't try and reduce those things to simple interactions, but try and think about things sort of like more from a holistic perspective. As we gain more competence, we might be able to be better at recognizing these different patterns. Some are more obvious than others, and some might be in the periphery. We might be better at recognizing the weak signals from these different things that are going on, and also keeping track of how this sort of develops in practice. So systems thinking is a way of organizing all of these things and hopefully getting a good grasp of these patterns. But I'll let Helen talk more about that now. If I could hand back to you, Helen.
That's wonderful. Thanks, Dominic. I had to laugh a little bit there where you were talking about the development of a driver through from a learner driver through to intermediate through to kind of advanced on the road. I'm going to talk a little bit about how important practice is in all of this decision making, and I've noticed that myself. I've been largely at home for the last 7 months, and I had to drive to Aberdeen Airport last night, and I think I'd actually regressed from probably even below intermediate status. So that's a nice way in which to move into thinking about practical solutions for complex environments, which I'm sure is what will be most useful for you as newly qualified pharmacists. So this work kind of started off, I didn't expect it to be quite such a big piece of work, and we took a fairly systematic approach to kind of looking through the literature and thinking about what was already known about decision making, and particularly clinical decision making, and the tiny little bit of information that was available to talk about how pharmacists make clinical decisions. So after all of that, we were left thinking, well, what do we actually know? And realised that there was a lot more that we didn't know. But we could summarise what we'd found as, first of all, decision making is dangerous, really. Particularly in healthcare, the stakes can be high, the costs huge. And these kind of fear of making a wrong turn that very often gets kind of shown in any sort of incident analysis haunts any clinical practitioner. But I think there's evidence to suggest that pharmacists find this particularly challenging. And I think some of that's to do with a punitive legislative framework that's definitely not helped the situation. The other thing we know is that it's an advanced skill. It's the hallmark of the expert practitioner. But interestingly, it's an implicitly acquired skill. And even advanced decision makers are unable to articulate how they actually come to a decision. So one thing that's definitely clear is that experience is necessary, and therefore it's a function of time. It's not just down to time, of course, there's more to it than that. experience kind of allows you to organize knowledge, to recognize patterns. So experienced practitioners will say, well, I know that when I see A and B, that probably means we've got C, and therefore I need to do D. So pattern recognition is absolutely critical, and that's actually what that design is on there. Any of you who've done any kind of clinical aptitude testing will have done that horrible abstract reasoning, and that's actually what that's supposed to be about. Look at your inherent ability to recognize patterns. But in this pattern recognition, one thing we know is that advanced practitioners actually don't always get it right, and they sort of recognize that implicitly in the way that they make decisions. And so what they'll be thinking about is, if they've got it wrong, what might be the alternative decisions that might be kind of hovering there in the periphery of the kind of consideration, and how would they recognize when things are going wrong, and how would they respond to it? And the other thing is apparent is that people want tools. They want practical tools to help them make decisions. And that's a nice idea, and there are quite a few out there, but they tend to be for less complex situations, perhaps when there's kind of protocol-driven questioning that can allow you to come up with a decision. A decision-making tool or decision aid might be useful there. But in terms of some of these complex clinical decisions, the sort of things that David's talked about and Dominic's mentioned as well, actually, the reality is there aren't any easy answers, and that's probably one of the main things that we really considered with this work. But one thing that we can do is we can actually speed up that development. We can encourage you on your pathway towards becoming an experienced and expert decision maker. And I think in doing that, there's three key elements. And the first one that I think is the most important is that you can borrow experience from other people. So that's about working with peers particularly and sharing their experience. And while of course you can just go to people and ask them what they do and think about how their decision might align with your preliminary decision, it actually becomes much more useful when you have some sort of structured form for peer discussion and the opportunity to practice. Because what that does is it starts to make the implicit explicit. And between you, you can learn a lot from each other and start to unpick what actually goes behind all that decision making. But beyond that, reflection is absolutely critical. And I know anyone who's been through a university course and then has to do their CPD gets a little bit fed up of reflection. But I think it's really important in revisiting your decisions, seeing if you know, a few months later you still think it was a sound decision. That's critical in terms of that cognitive organisation and developing that pattern recognition. And by doing this, you can develop that pattern recognition perhaps a bit more rapidly. Now, what we wanted to do then was come up with a kind of practical structure to allow you to have this structured discussion, if you like, that allows you to unpick what goes into decision making and to review and reflect on your own decision making development. And there's a model in aviation that I like quite a lot. I think sometimes not always keen on things necessarily being applied from aviation and healthcare, because I think it has caused us some problems. But threat and error management is a really good example of a framework that allows you to explore decision making. So before a flight, a crew will undergo the pre-flight brief, and essentially what they're doing is they're looking at that very specific flight, not a general flight, this actual flight that's happening right now. And there'll be a number of decisions that they'll need to make in terms of filing the flight plan and you know, making sure that this flight has the best chance of going smoothly on the day. But as part of that, what they'll do is they'll look at things called threats and errors. And we go into these in much more detail in the resource, so it's worth having a look at the theory behind this. But threats are essentially hazards to that flight. And they're things that are beyond the flight crew's control. So they might be predicted things like the weather. They might be unpredicted things like, you know, some sort of mechanical failure, or perhaps weather that wasn't predicted in the weather forecast. But they'll think about those and not just think about the threats themselves. They'll think about what those threats might look like and how they might unravel, and what might actually be the sequelae of those threats if they're actually realised. And here's a really important one, I think, definitely for pharmacists, is to think about errors. I know very often training is about trying to reduce errors or even eliminate them. pilots recognise that they will make mistakes, and they also recognise that those mistakes don't really belong to them. Students make typical errors, pilots make typical errors, and that's because the systems that they work in kind of force those errors. And because they talk about it a lot with each other, and they're talking about it in the context of the activity they do every day, they recognise which errors are likely to happen. So they'll think about all those in relation to this specific flight plan. But they'll go beyond that. They'll also think about what cues will arise that will tell them that things are going wrong. And they'll have already at least planned in some kind of preliminary detail, some sort of recovery strategy. And a good example of that is to think about the so-called miracle on the Hudson, where Captain Sullenberger lost both engines following a bird strike, and ditched, pretty spectacularly in the Hudson, and everybody escaped intact. That was because before the flight, they'd actually considered what might happen. They knew there was a lot of birds in the area, so that was a hazard, that was a threat that was going to affect them. But they thought about what might happen. I'm pretty sure they didn't predict both engines being lost, but they would certainly have talked about the impact of losing one engine. And they would have talked about recovery strategies that might have helped them survive that. And Sully, of course, was considered to have made excellent decisions in relation to that incident. But he said afterwards that he was very modest about it. He said that it was because these things had been practiced every day. He said this opportunity in training and in everyday practice to talk about decision making and to externalize those decisions made even emergency situations just to be the routine, the normal, and something that they could deal with relatively easily. And it's because of that being embedded in everyday practice. What you're saying is, can this specific pilot with this specific level of training and expertise fly this particular flight on this route in these weather conditions and safely manage it and land and be reasonably commercially expeditious as well? So don't forget that as well. And in short, what they're doing when they do this threat and error management is they're modelling their system. And in modelling the system in this verbalised way between a group of people with varying levels of experience, what you're gaining is deep insight into the different ways that people make decisions. And really critically, which is very relevant for healthcare, is their attitude to risk. And the more you externalise it, the better you model your system and the better the understanding you get, the better your decision making is likely to be. So we decided to apply this in practice for you by coming up with a framework that would help support decision making or more discussions about decision making within your systems. So we based it on a tool that's already used in NHS Education for Scotland, who's also a contributor to this resource. And they use something called Enhanced Significant Event Analysis. Now, it's based on a human factors framework called Systems Engineering Initiative for Patient Safety, and there's a little bit more about this in the resource. But essentially, it encourages you to identify all different entities within your system, so all of the people, including the patient, all of the activities that you undertake as part of any particular consultation or clinical interaction, but also to think about the environment in which that's happening. And to think about the performance influencing factors that will influence a decision and also make that decision perhaps be viewed retrospectively as problematic. And very often what you see when you apply this in incident analysis is that something that looks like a ridiculous decision to you with hindsight of the incident has actually been the result of being forced by the system. So environmental conditions or complex activities or issues with people that mean that those decisions seem to make sense at the time. So that's a retrospective model for thinking about decision making, but it can also be used prospectively, and that's what we've done with this resource. So we've combined a bit of threat and error management along with that modified version of SEEPS, and essentially what you've got is a kind of set of notepads there, and those notepads are for you to fill in. So those notepads will allow you to capture all the entities within your system And also you've got space to actually start to think about threats and start to think about errors. Now, I think that'll be quite challenging in the beginning, and it's not something that you'll wrap up easily, so don't sort of expect that to happen, but it's about starting these discussions. And when you're using these and you fill out the notepads, sometimes you'll find you've got gaps, and what that will do is that'll alert you to information that you need, and you can use consultations or other means of data collection to kind of address those gaps. But you also might see that you have an awful lot in all of the notepads, and that might give you some indication that your system is perhaps more complex than you might have first thought, and that would give you the opportunity to bring someone else in to help you with that decision. But you can use it in lots of different ways. You could use it on your own to support your activities, or I think you could also use it as something that you could share with your educational supervisor, and it could be you know, a kind of learning object, if you like, as a basis for reflection and discussion. But also get other people's input on it. So start building these relationships with peers and get their thoughts on a situation. These things can be done after the event, whenever you have the opportunity to meet up with people to discuss these things. And those things become your record of your development of your decision-making skill. If you file them and you review them regularly and reflect on them, that will give you the opportunity to start organising your thinking and building your pattern recognition. Excellent. So I shall now ask Steve to show the video, which is going to kind of capture one of these discussions. So a discussion between Hannah and Emma, showing how they discuss their system using this model. Thanks, Steve.
Hi, I'm Emma. I'm one of the Clinical Leadership Fellows working for Health Education England. I'm with Hannah Bieber, who joins me, who's a specialist diabetes pharmacist at County Durham and Darlington. And we're just going to work through a little bit of a case study where I'm going to act as the foundation pharmacist, having just recently come out of that role. So kind of using the human factors framework, we'll kind of do a bit of role play to show how it might kind of play out in practice. So, hi Hannah, did you get that case I sent over to you via email?
Oh yeah, thanks Emma. Yeah, it was a really interesting case actually. So shall we go through it? Let's refresh our memories because it's been a few days since I read it. So I've got a guy had just come in, age 70, admitted to an acute hospital trust overnight, and he'd had a fall when he came in. So I think it looks like he had all his blood pressure medicines withheld. He was hypotensive when he arrived with us. It looks like the plans were to investigate the cause of the fall, including the postural blood pressure and the monitoring, and then a pharmacy review of the medication was where you came in. And lots of things going on there. So comorbidities, chronic kidney disease, heart failure, previous MI, hypercholesterolemia, and type 2 diabetes. Well, this is certainly my bread and butter. And then we've got medication wise, he's not on too many medications, so that might mean that we've got somebody who has at some point had their medications reviewed. So metformin 1 gram BD, glycoside 80 BD, so that's morning and tea time, atorvastatin 20 on a night, ramipril 1.25 on once a day, not sure when, bisoprolol 1.25 once a day, not sure when, and he's got no drug allergies. Okay, so talk me through what your initial thoughts were on this.
So I saw him when it was a really busy day on the admissions ward, so I was quite stressed when I did see him, but I thought I would kind of use the framework to have a look at how I might prioritise and how I might work through the issues. So I noticed when I saw him that he wasn't on an antiplatelet, which I thought was quite weird because he'd had a previous MI. Also recognised that he had a significant cardiovascular history and also diabetes, so potentially his statin might need to be optimised and that dose might need to be looked at. So those were kind of two of the interventions that I noticed in terms of amending medication. Also because he'd come in with a fall, I had a little look at his meds, obviously, and ramipril, bisoprolol kind of jumped out to me as ones that can cause hypertension, and so they might need to be monitored, and we can have a little look and see what his blood pressure's doing whilst he's with us. Also, the glycoside can cause hypoglycemia, which can potentially precipitate a fall too. So that's what I kind of put as my interventions. And then did, my kind of notepad approach to addressing some of the human factors aspects of the case. So I thought about who are the people that are involved in the situation. So obviously the patient's the main one, and as I've already talked about, we had quite a significant cardiovascular risk, and he was missing potentially an antiplatelet and a statin being suboptimised. Also issues with his falls review medication and things that we need to monitor as a result of that. Obviously there's me that's in the situation, so I'm only a couple of months qualified, and it was a fairly complex situation, but I was quite comfortable tackling it because the patient's on quite commonly used drugs, and I felt that it was kind of within my remit to have a review over and make those interventions. So the second aspect of my notepad approach was looking at environment. So I know there's nice guidelines out there to help me look at lipid management and management of type 2 diabetes. So those are obviously really useful to help me kind of make evidence-informed decisions and highlight things. It was also really busy on the ward, as I've said, and with everything that's going on in the PPE and kind of additional barriers, that was quite challenging to then have that discussion with the patient. In terms of the activity, so I had to counsel the patient on diet and exercise, and could include kind of exploring what the current diet was. Also monitoring HbA1c and BMs, so we could ensure the diabetes was optimised and ensure that the fall wasn't related to hypos when we're kind of mapping trends in the patient's BMs. Also looking at blood pressure, so we needed to make sure we monitored that, so we could check that they weren't suffering from hypertension that might precipitate the fall, and also checking lipid profile and using these to ensure that those parameters are also not affecting any of the other things I've highlighted. In terms of threat, so the main kind of threat for me at that moment was more to the patient, so it was looking at cardiovascular risk. So kind of identifying that we needed to follow NICE guidelines, and that the patient was at a significantly increased risk. So that was kind of at the forefront of my mind as the main threat at that time. Also, the falls risk was there, and that was obviously the reason for the admission. So that was another one that was quite prominent. And also we know that falls risk is complicated, and we need kind of a multifaceted approach to be able to formulate that plan. So the threat was obviously that's quite a complicated thing to address, but it obviously had caused the admission. And also kind of time pressures and workload pressures that I've already alluded to. So I did find it really stressful, but at that point I kind of didn't highlight that there was any errors, and I was quite pleased with the job that I'd done. The one thing that I did want to talk to you about is that actually on reflection and discussion with my educational supervisor, Helen, who's actually looked over the case, she noticed that the patient actually was on aspirin, and that when she'd had a discussion with the patient's wife, had found out that he was just buying that over the counter, which is something that I've missed. Also, she had an in-depth discussion with her about the statin, and kind of identified that the patient was previously taken a higher dose, but unfortunately couldn't tolerate it due to side effects. So obviously we've had that kind of error discussion and reflection, but it'd be really good to see kind of how you would approach this scenario from a more expert point of view in terms of some of the decisions that might need to be made around this patient's care.
So I suppose from my point of view, just thinking about these different things, so people, environment, activity, threat and error. So people for me is not necessarily just the patient themselves, so he's definitely a part of this, and I think that just taking him to start off with, which is obviously something that you've spent a lot of your time focusing on. So I would want to think about frailty. So one of the first things that we do in our frailty clinics is to look, although he's only 70, sometimes people can be very frail at 70, so it would be to have a look at his frailty and then categorize that and set individualized targets for somebody. So this is where we're really starting to think about people, isn't it? That holistic care, that putting the person in the center of everything that we do, and setting those individualized targets targets based on our frailty scoring is really what we've been talking about a lot more in the diabetes world, is that we don't just take it as everybody needs to attain an HbA1c of 53, because that's how we get ourselves into trouble with things like hypos. So other people though involved is the rest of the MDT, and I would want to know what sort of stake have they had in all of this. So would want to see what I could do, but also what I can hand over for future review, because you're not going to necessarily sort everything out on an acute hospital admission, A, because you've not got enough time to, B, because you might not have all the information available to you. And some of the stuff around frailty, it may be that actually some of the information to do the frailty scoring appropriately might need to come from primary care. So you need to think as well about where's this person being managed most of the time. So if this was a different scenario, let's say this was somebody with type 1, then potentially actually the hospital team might be the people who know the most about this person, and then the continuity of care might be in-house. It might be communicating with our diabetic specialist nurses, looking at what we can do about getting monitoring or technology involved, and looking about that as a different approach to continuity of care. Environment, so where does this person sit amongst national and local pathways, and you know, again, he sits amongst all sorts of things here. So if we were to look at this from a guideline point of view, each one of these aspects of his comorbidities has its own NICE guidance. Activity, so what activity would I have done with this person? So from a blood testing point of view, I would certainly have wanted repeat lipids, which I believe that you also would have requested, and then looked at why he was on that atorvastatin 20 in association with that. With regards to chronic kidney disease, so there's some new guidance out on that around, it's called the KDIGO guidance, which is the kidney disease guidance around type 2 diabetes, and that's really lovely guidance that again talks about very holistic care for kidney disease in people with type 2 diabetes. So also about what adjustments I would make. So thinking about this person, obviously he's on metformin. That's fine, most people would be on that. I would leave that where it is unless he's not been tolerating for some reason. And again, there's a piece about finding out about compliance with this person. Don't think that you mentioned that. So I think understanding compliance and adherence around medications. Don't just take things that you got caught out by the aspirin. That's a good example. To be honest, sometimes when I'm in a rush, I do forget to ask myself about over-the-counter medications. So I think a really good point raised and reminded me as well. So we've got also threats. So lots of threats to the person, to ourselves as professionals here. These are high-risk patients to manage, and I think you've done brilliantly. So what it is you've got your cardiovascular risk to manage, which, like I've said, is the most important risk and the one that carries the most morbidity and mortality for people living with type 2 diabetes. So that would be my first thing to sort. Falls risk, so from a type 2 diabetes status, I want to assess him for any neuropathies, and that can add into a falls risk, and make sure also that he's got no foot problems, active foot disease. That would be something to look at, because for this person, if he's fallen, he might have a gait problem, and sometimes people can change their gait when they've got an active foot ulcer. So again, would that be a referral through to a podiatry team, for example, or working with a podiatrist colleague to try and get resolution? And again, time is your problem. I've talked this through. You probably wouldn't have had this much time to think about all these things and look at all these guidelines with this one person. Otherwise, you would have spent your whole day doing it. So it's about involving the teams, referral back, prompts to the GP to just look at some of these things themselves once you've discharged, and just highlighting some of the problems upon discharge. Error is the last thing to talk about. So lots of things that could go wrong with this person if they've got chronic kidney disease and they're having hypos, because that glycoside might be lingering around longer than it should be, or otherwise, then this is potentially an error. And sometimes the first time that we catch somebody like this is actually the most important time, because the next time might actually be a fatal error for this person. So it's important that we don't dismiss things like hypos on the first time that we're seeing them. So I think that's probably my top line things that I've thought about in those 5 things. I'm sure in the case study I thought about other things. I've probably said more here now, or different things, because I think, again, with diabetes you could probably come at it from so many different angles, but if you manage to even make a couple of good interventions with somebody, that's what really counts.
Thank you, that's really helped my understanding.
Wonderful, thank you both there. A couple of things that kind of really struck me there was just the sheer complexity of it, really. I kind of teach diabetes to pharmacy students, and no, I'm so way off on the complexity of it, I have to say. The second thing was, I loved the way there that the errors were kind of recognised, and they weren't in any way made to make the less experienced pharmacists feel as though they'd done something wrong. The errors were recognised as kind of being a natural part of it. Just wanted to comment on one thing that I'd seen in the chat there. The pilots are having a great discussion here about things like use of simulation and human factors frameworks. They've said that the lack of experience as a result of reduced flying during the pandemic has required everything to be overhauled. And I think that's a really important point to bring up that's very relevant to this resource, is that any of these things, these are provisional resources to start off with. When things change, it's wise to review things and to keep them constantly under development, and that's what we hope will happen. So I shall now hand over to David, who's going to talk us through how he sees these resources being used. Thanks, David.
Thank you, Helen. Yes. As you said, I think it's a really kind of good case study there to highlight a lot of the opportunity to use the resources to kind of consider how we make decisions within pharmacy in practice. My kind of reflections are that you could see how it kind of provided a clear structure for the reflections and wider conversations between the kind of supervisor, but it could also kind of provide structure to reflections and conversations between peers as well as supervisors. I think it promotes the reflection on the case and the complexity, and enables both the supervisor and the kind of foundation pharmacist to kind of actually make kind of visible the thought processes behind the decisions are made, and then properly kind of critically evaluate those decisions. I also think that Hannah won't mind me saying this, but I think it highlights also that experts don't know everything, but what they have developed is the ability to evaluate options and manage the uncertainty. And what the structure within the kind of frameworks that we've developed hopefully will do is enable people to kind of make better decisions and analyse their situations better. We use the situations there to actually consider different perspectives. I really like the way that Hannah kind of flipped the system and thought, what happens if it's a type 1 diabetic instead of a type 2? And that can hopefully prompt better kind of thinking about the systems we're working and the decisions we're making by kind of considering how we flip the systems and consider it from different perspectives. I want to also highlight that within the resources that will be shared after this webinar, there are community pharmacy and GP practice cases within those resources. So if you felt that that didn't necessarily chime with your experiences, there are other case studies within the resources that will kind of allow you to kind of think about how you might use them in practice. So I just wanted to go back to the notepads that Helen showed us earlier on, and highlight that there are blank notepads that will be available as editable PDFs or to print out as part of the resources that we'll share after this webinar, so that you can use them in your practice, both in real time or retrospectively, to consider the kind of decisions that you have making. So how do I see them actually being used in practice? Like I said, you could use them in real time to kind of consider the decisions you're making. Obviously, that is quite challenging to do. So they can also be used retrospectively to consider the kind of decisions and the complex environments you're working within. I've already mentioned that you could potentially use them to kind of flip the system, considering how you kind of different perspectives could influence the decisions you're making. And it's useful to then think about that whole system-wide approach that that Dominic was talking about earlier on. Also, within the wider resources that we'll be sharing after the webinar, there are more kind of there's more information about how you consider your own biases to make decisions, and how you could potentially use the resources to kind of do risk assessment or evaluate options within the kind of decisions you're making within the workplace. I'd also like now just to kind of share an own personal example of a complex decision I was involved with supporting earlier this week. With COVID, we know that patients' thromboembolic risk is increased. And I've been kind of quite closely involved within my trust about supporting the thromboembolic management pathways, etc. And so for a standard patient, we would use a low molecular weight heparin for prophylaxis in a medical patient. Then you could add an extra level of complexity that maybe that patient has got AF and happens to be on an anticoagulant before they came in. You then maybe add in an extra level of complexity that this patient is also obese. And then you throw in, on top of that, that patient maybe has COVID and critically ill in an ICU environment. And so you've got to consider all of those different elements of that patient's individual risk when you consider how you will manage their thromboembolic risk. And ultimately, there is not a right answer with a lot of this. The evidence base for a lot of the decision we're making with COVID in particular are not necessarily there. So therefore, we need to be able to adapt and understand the bigger picture and understand the systems that we're working within to be able to make informed decisions about the care we're providing. So how do I see you using the resources that we're going to share after this webinar? First thing, I'd encourage you to actually access those resources, and then have a look at the example cases that we've included within those resources. Have a look at the one that Hannah and Emma have walked us through, and you'll actually see that what we've done is just pulled out a small snippet of the massive complexity of that case. There is lots of other cases there's a number of other cases within the resources as well that may speak to your own individual experiences to be able to kind of understand how maybe you could use the resources we've got here to kind of consider how you make decisions in practice. The next step, I think, is then to have a go at using the resources. So either download one of the kind of notepads and actually fill it in using a complex decision you made, or maybe kind of go to the ward and use it to help, or use it with a case within your community pharmacy kind of environment to kind of think about how you've made decisions and reflect upon those decisions. And then use the educational supervision that is provided as part of the Interim Foundation Pharmacist Programme to support and kind of reflect upon those decisions and get the perspective of your educational supervisor. If you've not got access to an educational supervisor, maybe use peers or some other other people that you work with to kind of get their perspectives on how they might make decisions as well. Once you've had a go with using the resources to kind of consider how you make decisions, then it's probably worth going back and actually reading through some of the more detailed information we've got in those resources. Like I said, there's lots in there about kind of about bias and various other elements that influence decisions, and to use those kind of resources to actually kind of think about how you make decisions. So examples of case-based discussions, maybe to critically review an error or a near miss that you've been involved with. Or maybe even just to build your confidence. As I said earlier on, kind of confidence is one of the things that has been highlighted as a real challenge to develop kind of decision making as people progress in their careers. I think the other thing that is really important to highlight for provisional registrants who are on this webinar is that we're aware that you've got an exam coming up, and we know that the date was released on Monday. And I think that what these resources may help with is aiding you to understand the complex scenario you're working within, and then promote deeper learning, which then could be applied to maybe be able to answer the kind of registration assessment questions more easily. So going back to the whole kind of COVID thing, which is where this started from, I think that newly qualified pharmacists within kind of England and the UK wider have got lots of challenges to manage to develop their complex decision-making skills. There's the kind of whole exam issue, registration assessment that I've mentioned. There's the PPE. There's the changes in pathway of healthcare delivery. And we've obviously got the COVID vaccine, which was announced this morning as being approved, and how we deliver that. So we've got lots of challenges to how we can develop our clinical decision-making skills. But like I said earlier, there's lots of opportunities if you can develop your clinical decision-making skills to develop new roles, to advance your practice, and be at the kind of centre of patient care that pharmacy should be. So the last thing from me is just to say that if you are a provisional registrant, do engage with the IFPP to help support your decision-making. Register. There is educational supervisor support built within the IFPP, which will promote and support your decision-making using the resources we've shared today. So Steve, we've got one last poll to run just now before we have question and answers at the end. So can we run that last poll? So the poll's live there, if you don't mind filling in. So that will, the question is, how will you most likely use these resources kind of moving forward? What's your reflections on it initially? Great. So we've got plenty of people saying that they will use it to help develop foundation pharmacist decision making, to help discussions with educational supervisors, and to help review with complex decision making. Quite a lot of people are saying they'll use it in some other way. So if you don't mind kind of including that in the chat function after we've finished the poll, just to kind of share some of your other thoughts as well. And I'll hand back over to Helen for our final questions.
Thanks ever so much, David. If I could just ask the rest of the panel members to put their cameras on and to unmute their microphones now, that would be very helpful. Wonderful. I think for first question, David, that occurred to me, because I kind of reflect on being asked that quite a lot at these sort of events. Is this not just more work on top of already busy workloads? And how do you think pharmacists will manage to apply this when they're so busy?
I think it's a really good kind of question, that, and I think that the challenge that I've had talking to kind of people and supporting people with their kind of complex decision making, talking to kind of newly qualified pharmacists, is actually that developing your decision making will actually make kind of your life easier by going back to all those challenges that you have got as a newly qualified pharmacist that we saw in the research about confidence, about ability to kind of make decisions. By being able to kind of confidently make decisions, you can actually kind of deal with situations and challenges kind of in a more timely manner, and then be able to kind of actually improve your efficiency. There's work looking at about how pharmacists prioritize their workload, and a key element of that is how do you deal with complex scenarios and how do you make decisions about those complex scenarios. So if you can prioritize your workload, then you are better able to deal with the kind of the kind of time challenges that
Wonderful.
We all face.
Thanks, David. And that always reminds me, quite often that's what we get asked in sort of healthcare curricula. If you put human factors in, what do you take out? And I always say it's like that joke where a man goes into a bar and he asks for 8 pints of lager, 6 gin and tonics and 3 packets of crisps. And the barman says, do you want a tray with that? And he says, don't be ridiculous. I've got too much to carry as it is. Think of human factors as being a tray. I think these kind of approaches can actually sort of make things easier. Emma, in your video, you and Hannah sort of reflected on this discussion. And you were sort of playing the role of the kind of less experienced pharmacist, kind of going to somebody else to speak to them. Could you give us some insight into how you think people might use these tools with their educational supervisors in order to improve decision-making capability?
Yeah, so I found it really useful when I was kind of doing my foundation training to have those one-to-one discussions with your educational supervisor. So obviously as part of the IFPP programme and as part of the kind of GPHC requirements, you've got to have a kind of sit down with your educational supervisor once a month. So I think if I was in that position, I would be utilising that time to have that sit down kind of formal look over any events that have occurred or any case discussions that have occurred to kind of put some of those frameworks and use some of those notepads in practice. One thing is your educational supervisor might not be actually familiar with the notepad approach. So what might be quite good is if then you can show them how to use it and teach them the tool. That will obviously then reinforce your learning too of how to use the approach. And you can kind of see their take on it and see, you know, how they would interpret that tool and how you can both kind of come to a set of maybe learning objectives from that too.
Fantastic. And what do the others think about that? Do you think that might be used in that way, or other ways in which the tool might be used with the educational supervisor?
I really like that idea. I think that it's nice as well because it sort of aligns your practice with what's needed of you from the people who you are supervising. And I think sometimes I mean, we're not beyond learning, are we? I think that we're not, like David quite rightly pointed out, none of us are the finished article, are we? We're practicing, and that's the point in all of this, is that we still have new ways of learning to do things. So yeah. Yeah,
I think that's one thing. I mean, I have to say, I learned so much. I think I learned much more from this than I was able to give back into the project in a lot of ways. It was a very, very, very steep learning curve, and you know, definitely I think having it's those kind of mixed levels of experience discussions in all aspects of it that I think sort of really open up areas. Yeah, of course.
Helen, I'd like to add to that I think that it's really important to have different perspectives, and so pharmacies can be very internally focused, and we support each other and talk to each other. I think that one of my formative experiences as a practitioner developing was actually talking to my consultant colleagues and nursing colleagues. I used to kind of go regularly on ward rounds and be able to see their perspectives, see how they made decisions as well. And if I'd had the toolkit at that point and the notepads then, it would have been really helpful to then consider how they made decisions and then how I could make decisions. So it's not just a pharmacy kind of resource, it's about how we interact with the wider healthcare team.
Yes, and that was one thing that I was just thinking about actually as you were kind of discussing that was I know certainly you know, for those that don't know, I teach undergraduate pharmacists, and sometimes in kind of interprofessional activities, I would say it's one of the least understood relationships sometimes between the pharmacist and the rest of the team. So the rest of the team aren't necessarily sure what the pharmacist can do, and the pharmacist sometimes is a little bit hesitant about coming forward. And I wonder if these resources could actually be used kind of in interprofessional education as well, possibly, you know, as a kind of undergraduate activity to get used to using these resources, possibly. One thing I was thinking I'd like to ask Dominic, we've talked quite a lot about these super complex, almost chaotic scenarios, and I was wondering, does everything need to be treated in this kind of complex way? Especially if your understanding of complexity isn't great, and sometimes maybe you underestimate a system.
Yeah, so I don't think we should go down the route of treating everything in a complex way. I mean, there might be quite simple things to deal with, and then we don't need to add to the complexity to try and deal with them. So if there's a simple fall from a sort of a child in a playground, you know, they might just need some antiseptic, and that's a very sort of simple case, provided there's nothing else going on. I mean, if I had a fall as someone who's sort of like more middle-aged, then, you know, there might be other things going on. And if you compare that to my granddad with multiple morbidities, then, you know, that could be heading towards more complex cases. I think it's tricky as well, because sometimes we don't know which area we're in. So that's part of the skill. Something that presents itself perhaps as a more simple or complicated case might have complexities hidden within it. And I think that's where you need sort of that expertise to notice those weak signals, perhaps to draw those things out and recognize those patterns.
Yes, and I think that's obviously where the tool can be used to do that. Sorry, David, you want to add something there?
Yeah, I think just building on Dominic's point there, that actually it is really challenging. And again, from my own personal practice, it's often the case where there is a lack of complexity is actually almost more difficult. So you're thinking, trying to second guess yourself, am I missing something here? And you might have somebody on a massive long list of medication who has got lots of comorbidities, but actually there's very little kind of pharmaceutical input, whereas the next person might have a very small list of medicines or maybe on nothing, but actually need a large amount of pharmaceutical input. And that's where the experience kind of comes in, is being able to know when to stop and say, there is no need to continue with trying to find what the problem is here when there isn't actually a problem.
Excellent. Yes, I was sort of reminded then again, thinking back to the driving analogy, when you first start learning to drive, you're so involved with the kind of mechanics of driving the car, you don't notice most of what's going on. So you don't realize how frighteningly complex it is till you get a little bit more experience, do you? I would like to ask the panel generally, starting probably with Hannah as our living, breathing persona here. Dealing with complexity is really challenging. Do you have any tips for kind of novices getting used to this that will help them with facing that?
Yeah, I think that just reflecting back on my practice by doing this project with you guys, I think that reflecting back about where I started and how I've sort of built on that through my career, I think that certainly it's a busy ward environment, and I get that, and you arrive on the ward and, like you're saying, there's always blind spots that you're not sure of. I think that one thing that I started doing reasonably early on in my career is I started almost adopting like a layering effect, where I'd come to the ward, obviously tackle who I thought was definitely complex, and then from then on I would then clear off what I could, and then from sort of that day onwards, I'd then sort of get into more and more detail, because your week is kind of structured, isn't it? Monday is always utter chaos, and then you're sort of able to maybe spend a little bit more time as the week goes on delving a little bit deeper, and that's sometimes when you uncover some of the things that you might have missed the first time around. Actually, that sort of layering approach actually really helped me, because it then flagged what I'd missed in the first time around. And then I could incorporate the things that I thought that really I should have picked up maybe on the first time around, and I started changing my practice. So it was quite a quick sort of almost like reflective cycle that I adopted. Obviously, you can use these tools as well to do that. So maybe if you have a little bit more time, you can use the tools and then start thinking about how you might sort of start that sort of quick reflection, and then a more deeper reflection as maybe you have a bit more time with a few patients, and then that'll change the way that you practice. I think that's probably the most useful thing that I can offer there.
Yeah, I think that's a really good point as well. With using these resources, I don't know how David thinks about that, but about possibly even using them for kind of reflection in action, so that there's nothing wrong with having them there with you. And we were kind of envisaging that if necessary, you could print them off and laminate them, so you could actually use them with sort of dry white markers, that you could possibly use them to think while you're doing things and to kind of capture, actually articulate and record what you're doing at the time, that you can reflect on and maybe change in practice. Emma, question that perhaps I think would be interesting from your point of view as kind of closest in a way to many of the sort of provisional registrants. What would you think would be the kind of best learning environments for using some of these tools? Because I appreciate some are just probably you're not really going to be able to do this. So I'd like your thoughts on that.
Yeah, so it was just drawing on what David mentioned earlier in one of his slides. Using them in kind of your work-based assessments, I think, is the most kind of obvious way to implement them in, because obviously shows a different angle to a case. If you were looking at something like a case-based discussion, then you could consider how your kind of human factors approach should kind of complement your other kind of clinical analysis. As well, I think I would have really appreciated having something structured to use to look back retrospectively after maybe an incident hadn't gone so well. So I think it would help as well for getting feedback on incidents, and would provide a safe kind of nurturing structure that you could use, you know, on a one-to-one with your educational supervisor, or equally just a peer if you maybe just wanted that support too. I think the thing with the framework, it's probably going to be a little bit awkward to use initially, but it's just that, you know, the more you use it, the more you'll probably get used to it. So my advice would be, it's probably no ideal learning environment. It would just be to take the plunge, try and use it, see how you find it. I think it would be a really good idea to have it printed and have it there, just even as a pause. So if you find yourself in a particularly complex situation that might be quite stressful, the ward might be quite busy, you might have a really busy pharmacy, but actually just pulling out that framework and even just taking the time to pause and think about your decisions, gain a clear head, I think would be really beneficial, even if you don't actually find that you fill that much in on your notepads. I think it just gives you almost a little bit of an excuse to have that headspace too, and then it might therefore encourage you to use it a bit more in practice.
Wonderful. Thanks. That mother-in-law always says that my head's too full. I need to get everything down. There's just a couple of things that I'm seeing that are coming up in the chat that I think are very relevant. I noticed Angela's there said about having to think about fatigue and things like that. I think those are all part of those environmental factors, and you might end up using the notepads quite narrowly to start with. You know, perhaps thinking of the entities as being the things that you can see in front of you. But gradually, as you get confident with using it, you might start to think a bit more laterally, and things like fatigue or your personal life, how things are impacting on your performance are very important to consider. And that also reminds me, there was a question elsewhere in the chat, and it's about saying, you know, is there a quick and dirty tool that you can use for making decisions? What I would say is with this tool is what we're trying to do is encourage you to kind of open up these discussions, just to start thinking more explicitly about your decision making practice. There will be loads of other decision aids and things that, like Hannah was talking about, the layering, that you might be able to pull in. And I know Angela's SMAC Squared tool would be a fantastic thing to bring in. So don't worry about that now. I'll talk about, this is going to be an ongoing development, we hope, and we'll start to build more resources around this document. But you can use it as the framework for supporting that. David, did you want to add something?
Yeah, I just wanted to kind of answer that quick. And how do you use it, quick and dirty? It's your own personal kind of filling it in. So as you said, if you can have a laminated copy that you can be using for making decisions, and you don't need to fill it in yourself, you can just kind of mentally tick yourself across. So it could be a kind of 20-second review using the tool, or you could do a full kind of half-hour review of a complex situation. But it's all just trying to prompt your thoughts, and it'll become instinctive quite rapidly with time if you're using it over and over again to kind of consider how you make decisions.
Wonderful. Thanks, David. Now, I'm very aware that we're getting to the end of our time now, and I know a lot of you are probably still at work and desperate to get home for something to eat. So thanks everyone ever so much, and I'll just hand over to Steve just to finish off for us. Thanks, Steve.
Helen, thank you, and to our panel, thank you very much indeed, to David, to Emma, to Hannah, and to Dominic. Helen, you've navigated us bang on time. Well done. I've certainly enjoyed the session, and I know you've kept our audience, an audience of over 250 at one stage. So well done. It's been a pleasure to put this session together with Health Education England. I hope you've enjoyed it, and if you have, then please tell your friends and colleagues. If you're interested in learning more about what human factors people do, and specifically what the Chartered Institute got up to this year, 2020, a momentous, extraordinary and very eventful year for all of us, I'm sure, then this time next week, 5 p.m. next Wednesday, there'll be a look back at 2020 and what's happened in the world of human factors, and also a little glimpse forward as to what human factors people might be getting to grips with in 2021. So that's about all we have time for now. It's again my pleasure to thank all of our panel, including Hannah and particularly Helen. Chairing these things is often quite a challenge. You keep your eye on lots of things, so well done to you. It's been a great session. The chat will remain open for around about 10 minutes. So if you want to say some final goodbyes or to make any comments, then chat will be open for around about 10 minutes or so. Okay, all that remains for me then is to say thank you for attending. We very much hope to see you on one of these sessions in the future, and goodbye.